Good morning, good afternoon, good evening to those of you attending from the US, from Canada, from Europe, from India, and elsewhere. It's my pleasure now, on behalf of the Velo CMC Foundation in New York, to introduce Anna Pulimood, MD, PhD, Professor of Pathology at Christian Medical College in Velo, who will be the second speaker in a three-part series on CMC's commitment to excellence in healthcare. This second lecture is entitled The Impact of CMC's Education Experience on the Health and Well-Being of India. Dr. Pulimood graduated from the Christian Medical College in 1987 and completed her specialization in pathology at CMC in 1995. In 2010, she completed her PhD in her primary area of interest, which is inflammatory bowel disorders, specifically relating to the differentiation of intestinal tuberculosis from Crohn's disease. Her work in the area of Crohn's disease has been widely accepted both nationally and internationally. Her interests in academia and management led her to advancement into several administrative posts at CMC, initially in the management of CMC's USAID ASHA grants, and then in the field of education as the Vice Principal for the Undergraduate Medical Curriculum and Vice Principal for Human Resource. In 2016, Dr. Pulimood was named Principal of the Medical College, where she became responsible for the management of all academic affairs and research. In 2022, she stepped down from her role as principal and returned to active clinical staff as professor of pathology. Apart from her academic interests, she helped start a solid waste recycling project with the help of a local NGO and women's self-help groups for all the non-medical waste generated in the institution, which is over 20,000 pounds a day. So once again, it's with great pleasure we ask Dr. Pulimood to speak to us about the impact of CMC's education experience on the health and well-being of India. Dr. Pulimood will elaborate on how the unique CMC educational experience encourages students to promote outstanding healthcare initiatives through the Indian subcontinent and beyond. And as Deepika mentioned, we should have some time for questions at the end of the presentation. Please feel free to use the chat function in the Zoom application to frame your questions for Dr. Pulimood. Over to you, Dr. Pulimood.
Thank you, Christy. I'll just share my screen. So thank you to John and Deepika and the Velo Foundation for inviting me to give this talk on the impact of education in CMC on healthcare in India. And thank you to Christy Thomas for that kind introduction. There are more than 600 medical colleges in India, more than 46 in Tamil Nadu. Are we unique? Is our training unique? Is our impact unique? Over the next 25 minutes or so, I will try to show you why I think education at CMC Vellore is unique, some of our current unique educational programs, and 5 case studies of our graduates who have impacted healthcare in the country, with a brief outline of some of our values, and finally finish off with a broader perspective of our contributions to healthcare in the country. So to start off with education at CMC, our mission statement is that we strive to develop through education and training, compassionate, professionally excellent, ethically sound individuals who will go out as servant leaders of health teams and healing communities. CMC has a special concern for the disabled, the disadvantaged, the marginalized, and the vulnerable. So most medical colleges will be trying to train people who are professionally excellent, and I presume that most of them will want ethically sound graduates. So what are the special qualities of education in CMC? I think one of the things that we try to do is plant values, special values. Compassion, servant leadership, and that special concern for the disabled, disadvantaged, marginalized, and vulnerable. I think these are the special aspects of education in CMC. We're trying to plant seeds of these values in the hearts and minds of the students who come to us. And then we try to nurture them during the few years that they spend with us so that when they go out, These seeds are firmly embedded in the soil of their hearts and minds, so that they bear fruit as they go out into their careers. So what are the different aspects of education in CMC that probably do influence our students to become what they do become? We start off with the selection of candidates. Now, of course, we don't have that privilege, but we used to have a very rigorous process of selecting candidates by trying to identify those who are best suited for our mission at CMC. A very particularly important aspect of this was trying to identify those with an attitude of service, willingness to serve people when they finish. Our academic standards, of course, are extremely important. It's what keeps us at the top of the medical college list in the country. But also, our students are not going to perform well as graduates once they finish unless our standards are good. So we do give a lot of importance to maintaining high academic standards. The great hospital that we have, I think that's where our students learn. So the fact that it's so good that people come from all over the country and other countries for treatment here makes that educational environment so special. The outreach programs of the hospital in the communities around us, that again is a very important aspect and a basis of training students. And I'll outline that a little bit more in the next few slides. Role models are very important. Our students have role models among the faculty. They have role models among the alumni who come back to the institution periodically. They have role models and visitors who are invited to come in and interact with them or give talks. And that also has a great influence. We teach ethics. And we teach it at the bedside. We teach it in the curriculum. I think that's a very important thing. Caring teachers. I think caring teachers who spend a lot of time with students is probably one of the best parts about education in CMC. And I have a slide on that that's coming up. Hostel life, campus life, very important for the holistic growth of young people. They learn to live with others, with a very diverse group. They learn to take up leadership roles. They learn to handle problems in day-to-day living, so much that can't be taught in the classroom. The research that we do, that is, we try to make sure that our research is something that impacts healthcare, something that's relevant to the problems of our country. And I think students learn from whatever research they come into contact with. Various educational programs in the institution, very specially developed to sensitize our students to the community, to the problems of people around us. And I'll be touching on those in the coming slides. Subsidized education. Subsidized education is something that we've upheld from the start of the institution. We want to make sure our students don't have major educational loans and financial burdens when they finish with training here. They're free to serve. We do have the mandatory service, but they don't have to worry about making money when they finish. I think that contributes to the way they're able to look at the kind of jobs that they take up when they do finish. Spiritual growth is something we give a lot of importance to. Bible class, class prayers, retreats, common worship with the community. Chaplaincy gives so much of thought into the programs that go in for, to develop students spiritually. Internship. Internship is such an important part of our education here. It's when students learn to translate everything they've learned in class into practical medicine. And I think, again, it's one of the best parts of our training in CMC. And students who finish internship here are able to go out into the mission hospitals and function as independent doctors. The mandatory service commitment. This is, again, something that from when they join here, students know that they have to go out and serve the community when they finish. They actually have to do that when they, after their internship. And that's a place where they learn to deal with the problems in communities and societies in disadvantaged areas. And that's a crucial part of education in CMC. So time spent by teachers with students. Interestingly, these surveys on the best medical college in the country ask us to calculate the amount of time we spend teaching students. And 38,325 teacher hours is the time that we give for medical students in an academic year at CMC. It's an immense amount of time. And if you look at the amount of time that students spend with clinicians by the bedside, with the patient, it's an incredible amount of time. I don't think any other medical college in the country can give that much of time to students. And we do have reports from other top colleges. This is a very, very special part of training in CMC. We have individualized teaching because a lot of our teaching is in small groups. There's academic mentoring, especially in the first year. Every student is given a mentor from among the preclinical teachers. We have in the social dimension, we have foster families. We have people who help with counseling students, and involvement of faculty in the extracurricular activities also ensures that we see students outside the classroom. Just as a side a piece of information, if you look at every medical college in the country, there's quite a good number of students who commit suicide every year. The pressure of medicine, the pressure of peers and family, all this is often too much for many young people, and suicides are common in every medical institution. But I must say, and God has been so kind to us, but we have not had that kind of problem here in our medical college. We do have people who have suicidal thoughts. We have people who do try, but there's a huge network of students and faculty and counselors and psychiatrists and so many just well-wishers in the campus who pitch in and support students when they're going through a crisis. What are our special educational programs? I think the curriculum is fixed by the National Medical Commission. Everybody teaches the same subjects. But our community orientation programs and our exposure to secondary care is something very special in CMC. The community orientation program started in the 1970s to introduce students to life in the village, to the attitudes of people there, and the demographic, socioeconomic, and environmental aspects of health is a very important part of training. Students actually go out and live in the villages and learn about the people and the health problems there. In their second and third MBBS, they do actual exercises in community health. In their second year, they do surveys on morbidity and mortality. They do a health planning exercise. They learn about the government health services and collect information on cost of treatment, distance travel to obtain medical care, and the utilization of health services. In their third year, they learn to work in teams on a given health problem. So students are divided into groups and are given a health problem. They have to study it in the community and learn to make a community diagnosis through surveys or existing data, and then plan and implement a program related to that problem. This is a fantastic learning experience and is a real hands-on time for students to learn about tackling problems in the community. The secondary hospital program is something that existed unofficially for a few decades, but in the 1990s, Dr. Anand Zakaraya formalized this program to create challenging experiences for our students visiting mission hospitals that belong to our network. The objective of this program was to sensitize students to the relevance and challenges of healthcare in these hospitals and to develop a positive attitude towards care in rural locations. They're posted in groups. They're allowed to choose their group so that they go with a fun team. They are accompanied by a faculty member from CMC and also supervised by faculty in that peripheral hospital. Students get inspired, they find role models, and it often has a great impact on their decisions on their future careers. Some of the quotes that students have raised are that these SHPs give us an idea of the real needs of the community, provide a scope to venture out and build challenges. In short, play a trailer to a real life that we're very far from in our medical college. One of them said, what shocked me was the hard work, perseverance, and commitment of the people who worked hand in hand as part of the team in that hospital. I realized that life and work in rural areas with the less privileged and no great facilities is no less than the work done in tertiary hospitals. So now we go on to 5 case studies of transformative work done by graduates and couples from our institution in different parts of India. And I've chosen examples from over 4 decades of our alumni. So I've chosen somebody who's worked with the hill tribes in Tamil Nadu in the Nilgiris, somebody who worked in a couple who worked in rural Maharashtra, a couple that worked in a town near Allahabad in Uttar Pradesh, a lady who worked in multiple metropolitan cities, but especially in Calcutta, and then a graduate who worked in the northeastern part of India. So the first case study is that of Joy Ceremony, batch of 1948. After completing her medicine, she did a diploma at the Royal College of Obstetrics and Gynecology in London and finished in 1960, following which she was married to Mr. Paul Ceremony, who had a transferable job. So she had to work in multiple places and did not take up a regular full-time job, but worked honorarily in various projects and outreach programs. So her first job was in a leprosy outreach program on St. Mark's Road in Bangalore. And while she was in Bangalore, she helped set up the Medico-Pastoral Association that started a professional counseling center for those who needed help. She was also instrumental in getting land from the Bangalore Corporation to start a halfway home for unmarried mothers for their rehabilitation and counseling, and to help them integrate into their families and society. After moving to Mumbai and Durgapur, Mr. Paul Ceremony and Joyce settled in Kolkata. And while she was there, she read an article in the newspaper about mentally ill individuals languishing in the jails of West Bengal. She visited the jails and was appalled by the dehumanizing treatment given to the inmates there. The mental hospitals were no better. Many of these chronically ill women were ostracized by their families and communities and cut off from normal human contact. She was moved by their plight and eventually established the Paripurnata Halfway Home, the first psycho-rehabilitation center in West Bengal, with 6 and then 8 beds. Women were offered pharmacotherapy, psychotherapy, non-formal education, domestic, social, and vocational training skills to prepare them for self-employment and a life of dignity. Recognizing her work, the state government offered land to expand beds from 8 to 30. And this is a picture of the Paripurnata Center today. The Nimhans Institute in Bangalore came forward to support work she was doing with alcohol and drug addicts and those with suicidal intent, and invited her to drive an awareness camp to deal with these problems and to create awareness. In her words, we not only want to prevent social evils, but also tackle these victims so that they have a recovery period that brings them back to normalcy, because rejection is a curse and stigmatizes the abandoned and unwanted by society. Even after her retirement, Joy Ceremony moved to Chennai, and there she continued to support the elderly in a home that she started called the Banyan Home. In the words of an article on her in the Asian Age in 2013, for some, it's never too late to make one's life more beautiful. My case study too is on the Aroles from the batch of 1954. In the early 1970s, leaders of the WHO identified a group of projects and programs that implemented a new approach to the provision of healthcare services that were relevant to the realities of developing countries. These projects and programs provided inspiration for the global primary healthcare movement. This movement began with the first international conference on primary healthcare at Alma-Ata in Kazakhstan in 1978 and its declaration of Alma-Ata. Foremost among these programs, at least in terms of its influence on the ideas and concepts embedded in the Alma Ata Declaration itself, was the Jamkhed Comprehensive Rural Health Project, established in rural central India in the state of Maharashtra by Rajnikant and Mabel Arole. Raj Arole was born and raised in the village of Rahuri in Ahmednagar district in Maharashtra. He met his wife-to-be Mabel at CMC, and both of them came out as MBBS batch toppers from the batch of 1954. After they were married, they worked in Maharashtra for a year in a mission hospital before going to the US on Fulbright scholarships to equip themselves for the life work they had set out to do, serving the poor and marginalized of their state. After they finished, they moved to Jamkhed, near where Raj was born, a location they chose largely for its desolation. They realized that the vast majority of sickness in rural areas could be prevented with clean water, waste disposal systems, and more diverse farming. Villages needed to end deadly superstitions about health. They needed to end discrimination against women and people considered to be untouchables. They needed to learn about hand washing, nutrition, breastfeeding, and simple home remedies. Normal doctors did none of these. They trusted in the capacity of poor illiterate women to provide basic health services, and as a result achieved a miracle: widespread community collaboration across a divided caste system. After the Aroles arrived in Jamkhed, women and family groups have been working together to reduce child mortality, improve nutrition, revive land and incomes with organic agriculture, and strengthen local governance. The infant mortality rate in Jamkhed declined from 176 per 1,000 live births to 20. Childhood malnutrition, which was present in 40% of the children at the outset, disappeared. The quality of life improved drastically. Over 50 years, this program has worked with 300 villages and over 500,000 people. The indirect impact is estimated to be at over 1 million. The model they set up was introduced in 178 countries across the world. My case study 3 is that of Chongtu Biekmawa, batch of 1964. The youngest of 9 children, Biekmoya grew up in a village in Mizoram near the border between India and Myanmar. Being a remote and backward area, 4 of his siblings died due to lack of health care. He was sponsored by the Presbyterian Church in Mizoram and joined CMC for his MBBS. During his time here, several Australian missionaries had a formative influence on him in his future work. After graduation, he returned to a hospital run by his church in Mizoram, where he worked till his retirement in 2005. The first 6 years, he was forced to work as a self-trained, multi-competent family physician because of the diverse needs of a remote community with very few specialists. But then he was able to go to the University of Liverpool and return as the first qualified pediatrician in Mizoram state. Child health services expanded greatly with a large number of admissions every day. He also made frequent and extended medical visits to distant parts of Mizoram with no access to healthcare, going from village to village in difficult terrain. His work on the relationship of vitamin A deficiency and childhood morbidity led to the widespread use of vitamin A supplementation in the hospital's community health program. Under the leadership of Biekmoya, the Dirtland Presbyterian Hospital became an exceptional model of mission hospital growth and development. Over 3 decades, it grew 3-fold in bed strength, 4-fold in staff strength. Specialist services, laboratory services, community outreach programs, and a nursing school were added. A part of the credit for the considerable improvement of health indices, and especially child health in Mizoram, goes to the work of Biekmoya. I'm sorry. I'm sorry, I think I've lost the screen. I'll just be back.
So Anna, we can still see the screen.
Okay, I'm not sure why I'm not able to see it.
You could try stop sharing and then screen share again.
Okay. Yeah. Okay. So this is a picture of the Dirtlang Presbyterian Hospital as it is today. The next case study is that of Nandakumar Menon, batch of 1967. After completing his MBBS in CMC, Nandakumar Menon did a residency in the US, working as attending surgeon and clinical assistant professor before returning to India. He arrived unannounced in Gudalur, home of the Adivasis in the Nilgiris of Tamil Nadu, at a hospital started by a younger couple from CMC. And here you see a picture of Rupa, who was one of the people who started this hospital before Nandakumar arrived there. The Adivasis are the original inhabitants of India, among the most neglected people in the country. Over generations, they had been deprived of the land where their ancestors had lived. They lived scattered in the rugged terrains of the hills with little sense of self, no means to earn a living, and no access to healthcare or education. Infant and maternity mortality was sky high, immunizations unheard of, and malnutrition rampant. Nandakumar realized that an acute medical care facility alone would not be enough to change a whole society. He recruited funds and manpower, and his wife Shaila with Nandakumar orchestrated a sea of change, a nursing program for Adivasi girls and training them as health animators got them involved in the healthcare of the hospital. An association for health welfare in the Nilgiris, the Ashwini, was born. An innovative health insurance program was started that served as a model for others. Nandakumar's maxim of give a man a fish a day and feed him for a day, teach him to fish and feed him for a lifetime, got him involved in the economics of the society. The Adivasis started growing tea and coffee. They organized themselves politically and fought against social injustice. A school was built, the hospital grew, and physician volunteers from India and outside joined the group. 20 years later, eclampsia, tetanus, and maternal deaths were almost unheard of. Infant mortality declined sharply, and death and maternal mortality was unheard of. The Adivasis were glad to avail of the medical care provided at the hospital. Nandakumar continues to work in Gudalur, and people previously on the fringes of society have been integrated into mainstream society today. My last case study for today is that of Premal and Loretta Das. Leprosy is a stigmatizing disease that disproportionately affects the poorest, most marginalized, and those with least access to healthcare. Premal drew his inspiration to work for individuals suffering from leprosy, initially from his family and later from Dr. Ernest Fritchie, a renowned reconstructive surgeon at Vellore. After completing their PG training in CMC Vellore, they returned to the leprosy mission to continue their life work, ultimately at Naini, a hospital in Uttar Pradesh. Over the years, there's been a steady increase in the number of new patients coming to this hospital, belying claims in India about the elimination of leprosy in our country. The workload has been challenging given the paucity of resources, but patients were drawn by the quality of care, compassion, sensitivity, and measure of trust that seemed lacking anywhere else. There are few centers in the country for reconstructive surgery to correct deformities of leprosy, and Premal, with his skill, played a vital role in restoring a measure of dignity to these patients. He's conducted numerous reconstructive surgery camps in different parts of the country, in Nepal and in China. Here you see a picture of staff in the hospital tending a man with an injured foot, and the other patients watching on. In patients with leprosy have a lack of feeling and develop a small cut or an injury becomes large and eventually results in severe damage to the foot requiring amputation. So this is care of the foot, and now that leprosy has drugs, and if they're treated early, you can avoid these complications, but patients with major complications of the limbs and eyes are still seen in different parts of India, and Naini is still doing a great job in treating these patients. Team building has been an important part of the work of Loretta and Premal Das, and they've also developed departments of physiotherapy, occupational therapy, prosthetics, and footwear to deal with the complications and disability management of leprosy. This hospital is recognized as a tertiary referral center for the management of leprosy by private and the government. Loretta has developed various protocols for the management of leprosy and is always on calls for doctors from other TLM hospitals. Training and capacity building of government staff in leprosy, doctors, nurses, physiotherapy trainees, public health inspectors, and field workers is a key priority. They publish many research papers and are part of multiple national and international research projects. Premal is currently the executive director of the leprosy mission based in New Delhi, but both of them continue to work in Naini because of their commitment to the care of patients with leprosy. So I'm sure that you'll agree that these 5 case studies do highlight some of the important values that we try to impart to our graduates: compassion, servant leadership, concern for the poor, the disadvantaged, and the marginalized. And I thought I'd say a few words about these values. I did not want to say anything before the case studies because they may seem like mere platitudes. But I think now you'll understand when I say that compassion by the Oxford Dictionary is a feeling or showing of sympathy and concern for others. But the biblical understanding is to empathize with someone who's suffering and to feel compelled to do something about that suffering, to see the pain of others, to feel it, and to act on it. That is compassion. And that is what our graduates are doing today. Servant leaders. Robert Greenleaf is one of the people in the US who first popularized the term servant leaders. He said, servant leader is servant first, sharply different from one who is leader first. And the difference between the two manifests itself in the care taken by servant first to make sure that other people's highest priority needs are taken care of, are being served. The best test and difficult to administer is, do those served grow as persons while being served become healthier, wiser, freer, more autonomous, likely themselves to become servant leaders? And what is the effect on the least privileged in society? Will they benefit? Will the least not be further deprived by our work? And concern for the poor, the disadvantaged, and marginalized involves identifying with them, working for them, giving of time, financial resources, and energy, standing up for them. And behind the scenes of real service, there's a lot of self-denial and self-giving. They give up a lot of the things that most of us crave. They face the problems that we normally don't face. They give of themselves, they deny themselves, and truly live up to the motto, not to be served, but to serve. These are some of our outstanding graduates. And if you look at them, they are actually from a list of those who have been given the Paul Harrison Award by CMC for a lifetime of selfless, steadfast, and significant service in needy areas, in mission service, or in disadvantaged and unrecognized services. These are just a few of the people whom have been named by our institution and honored by us. And then, of course, we have people who have been honored for 25 years of meritorious service after their graduation or post-graduation in CMC for continuous work in our mission hospital network. This is our network, and we have people working in all these different hospitals and spending, a lifetime of caring for people in these remote rural areas. So if you look at beyond the people who are working only in remote areas, we have totally trained about 4,348 medical students, 3,461 postgraduates, and majority of our students do have completed a service obligation in these hospitals. So everybody has spent at least 2 or 3 years working in these needy areas. 100% of our MBBS students complete their service. 30% work in peripheral areas more than 5 years. About 5% spend their entire career in these rural areas. Altogether, CMC has given thousands of years of service to the poor and needy of India. And this is not mentioning the Department of Distance Education. This is a very vital and growing department, started just maybe a decade ago by Dr. Vinod Shah himself, one of our Paul Harrison awardees. They have trained over 5,000 doctors, many of them government-sponsored in family medicine, psychiatric care, geriatric care, rehabilitation medicine in different parts of the country. Over 2,000 community lay leaders, ordinary people working in healthcare like community health workers have also been trained by this distance education department. These are some of the comments of people who've gone through their distance education programs. One on the family medicine course has made me a better physician and, more importantly, a better human being. It's made a significant positive impact on providing healthcare services at the grassroots level without the need for referrals or compromising the quality of service. A person who did the PG diploma in geriatrics said, the course was helpful in updating me. We serve in a remote location with impoverished people and have been challenged by the geriatric issues we've not been able to address. The course has helped me to explore cost-effective and evidence-based interventions for our patients. Currently, the Department of Distance Education is working on a project funded by Bill and Melinda Gates and training over 1,000 state health mentors and 36 that will eventually lead to the training of 36,000 community health workers for the entire country. A major impact that CMC will have on healthcare at the grassroots level. So I'm sure you'll agree with me that education in CMC Vellore has had a significant impact on healthcare in India and will continue to do so. I think it's because the seeds we plant grow into trees of life. The values we impart grow into these big trees that bear fruit and in turn have seeds that go on to multiply our efforts and continue in helping us build the kingdom of God. Thank you for your kind attention.